We are very lucky today to have Dr. Andrew Varga for his grand rounds on sleep, cognition, and risk for Alzheimer's disease. Dr. Varga completed his PhD in neuroscience at Baylor before going on to attend medical school at New York Medical College. He completed a residency in neurology at BI Deaconess in Boston, and subsequently went on to complete a sleep medicine fellowship at NYU. As a sleep physician and neuroscientist, Dr. Varga has had a long-standing interest in the mechanisms of learning and memory, and the role of sleep in memory consolidation. He has active R01 and R21 funding for clinical and translational research studying the role of sleep in neurodegenerative diseases such as Alzheimer's disease and Parkinson's. Dr. Varga currently serves as an assistant professor in the Division of Pulmonary Critical Care and Sleep Medicine here at Mount Sinai. Please join me in giving a warm welcome to Dr. Varga.
All right, well, thank you very much for the invitation to be here and for allowing me to share a little bit about what my lab works on in the way of sleep and cognition and Alzheimer's disease. So sleep is thought to be important for memory consolidation, but the validity of this statement depends in part on which stages or features of sleep are being implicated and what types of memory are being tested. So sleep is broadly divided into non-REM and REM sleep stages, with non-REM divided further into stages 1, 2, and 3 that reflect increasing levels of depth. And sleep and wake vigilance states are defined predominantly by the frequency of brain waves that you see in that state, such that wakefulness has a predominant 8 to 13 hertz frequency that's called the alpha rhythm. As you go from wakefulness into non-REM stage 1 sleep, you can see that this starts to slow down a bit. The frequency gets more mixed. You can still see some periods of alpha, but then you start to see some slower rhythms in the 4 to 7 hertz range, which are known as theta waves. And then as you get into deeper sleep, non-REM stage 2, the rhythm is generally more uniformly slow, but you can get some bursts of high frequency activity in the 12 to 16 hertz range that are called sleep spindles. And you can also get these large amplitude deflections that are low frequency that are called K complexes. And then as you get into non-REM stage 3, you can see that the amplitude of the waves is more uniformly large, and the frequency is the slowest that you'll see during any of the sleep stages in the 0.5 to 3 hertz range. And so these are called delta waves or slow waves and are characteristic of slow wave sleep or non-REM stage 3 sleep. And then REM sleep is very different neurochemically and was often called paradoxical sleep for many years because the rhythm can look a lot like wakefulness. There can be a lot of alpha in there, but there can also be a very predominant 4 to 7 hertz theta range. And the morphology of these waves is thought to be somewhat sharper and have this sawtooth appearance, which is characteristic of REM sleep. And in the same way that sleep is not a unitary phenomenon, memory can also be divided into a variety of subtypes. So you have things like declarative memories for facts, episodic memories for events strung across time, emotional memories, implicit memories, things like perceptual memories or procedural motor memories. And in this talk, I'm going to focus quite a bit on spatial memories, and in particular on spatial navigational memory, which I define as the ability to recall routes to salient targets in novel environments. And there's a few reasons for this particular interest in spatial navigational memory with relationship to sleep. And the first has to do with this idea of replay. So it turns out that hippocampal play cells replay patterns of activity during sleep that were recorded during periods of active exploration during prior wakefulness. And this is work from mostly rodent models. And it turns out that this replay occurs most reliably in slow wave sleep, but you can also see it in REM sleep. And so this is a mechanism by which sleep disruption is likely to have an acute effect. When sleep is disrupted, this replay isn't happening as efficiently, and it's thought that disrupts the consolidation or processing of the spatial information that occurred earlier during wakefulness. And I should just point out that the 2014 Nobel Prize for Physiology or Medicine was actually given to individuals who identified hippocampal play cells or, quote, for their discoveries of cells that constitute a positioning system in the brain. Now, the other reason we're interested in spatial navigational memory in particular is because it turns out that spatial memory is one of the earliest forms of memory that's affected in Alzheimer's disease. And so this is actually from an ad for a medicine meant to treat Alzheimer's disease that says your patients with Alzheimer's dementia can feel like they're trapped in a maze. So as you guys are aware, Alzheimer's disease is a neurodegenerative disorder that can be appreciated even on the gross level. So this is a gross picture of an Alzheimer's brain that has widening of the sulci and thinning of the gyri, suggestive of atrophy and neurodegeneration. And on a neuropathological level, we know that Alzheimer's disease is characterized by neuritic plaques, which are made up of beta amyloid protein, and these are extracellular, and also characterized by neurofibrillary tangles, which are made up of the tau protein. These are largely intracellular. Now, current thinking about Alzheimer's disease is that there can actually be a very long preclinical phase that lasts years to possibly even decades. And that's represented in this figure here, where you see cognition, shown by the purple trace, going from some normal level at the bottom of the y-axis to some abnormal level at the top of the y-axis. And well before that in time, you see that there can be these other changes, such as accumulation of beta amyloid, shown in red, and this can be observed both in the spinal fluid and by brain imaging with PET, and also changes in tau, shown in the green tracing. So metabolism of beta amyloid and tau represents a second potential mechanism by which sleep and spatial memory interact, and it's for the following reasons. One is that sleep is thought to result in decreased production of beta amyloid and tau, which is possibly related to decreased neuronal activity in certain cortical regions during sleep. Additionally, sleep is thought to result in increased clearance of neuronal metabolites, including things like beta amyloid. And so this is a mechanism in which sleep disruption is more likely to have a chronic effect. You're not going to have your memory disrupted due to the small amounts of accumulation of beta amyloid and tau from one night, but when this happens over and over and over again across many nights and many years, you can get accumulation of beta amyloid and tau, increase the formation of plaques and tangles, and impact spatial memory in that way. So what are some of the tools that we use to study spatial memory and risk for Alzheimer's disease in our lab? Well, first, we developed a sleep-dependent spatial navigation task that I'll tell you more about momentarily. We also do a lot of spinal fluid collection, where we look predominantly at levels of things like beta amyloid 42 and beta amyloid 40 in the spinal fluid. We also look at levels of both total and phosphorylated tau in the spinal fluid. And then finally, we do a fair amount of brain imaging, and this includes some standard structural imaging that allows us to assess cortical volumes. And we also do some PET imaging, primarily to look at amyloid plaque load in the brain. And so today I'm going to tell you guys two stories about sleep, spatial memory, and risk for Alzheimer's disease. The first really is about what happens in the absence of significant obstructive sleep apnea. And here you're going to hear a story about the role of slow-wave sleep and its particular influence on memory and beta amyloid, and then a separate story on the role of sleep spindles and its relationship with tau. And then I'm going to switch gears a little bit and talk more specifically about the influence of obstructive sleep apnea on both memory and risk for Alzheimer's by virtue of modulation of some of these biomarkers. So we know that there's a number of changes that happen to sleep with aging. We know that slow-wave sleep declines with age. We know that markers of sleep fragmentation increase with age. Cortical atrophy increases with age. And slow waves are thought to generate in the frontal cortex. And some prior work indicated that slow-wave sleep might be particularly important for processing of some of these spatial navigational memories. And this was work that showed that the degree of cerebral blood flow, specifically to the right hippocampus, correlated with the degree of improvement across the night on a spatial navigation task in a small number of people. So this was only 6 subjects, but this at least suggested that slow-wave sleep might be important for spatial navigational memory processing, and set up the possibility that declines of slow-wave sleep with age might then impact the ability of older people to appropriately process spatial navigational memories. And so in this first work, we aimed to do a couple things, which were first to ascertain the consequences of aging on sleep architecture and sleep fragmentation, to examine the relationship between prefrontal cortical volume and slow-wave activity, and to determine whether the consolidation of spatial navigational memory that normally occurs across sleep is diminished as a function of slow-wave sleep disruption with age. So in order to do this, we had subjects come and explore a 3D computer-generated spatial maze and then complete 3 timed trials before and after sleep, with each trial capped at 10 minutes. So shown here on the left-hand side is a first-person view of the maze. This is something subjects might actually see while they're exploring the maze. And shown on the right is a bird's-eye view of the maze. And I should point out that subjects never actually see this, but they're perhaps able to imagine it in their mind's eye by virtue of their exploration. So in this work, we had a group of older subjects who were cognitively normal by neuropsychiatric testing and had no sleep complaints. They numbered 13 total with 8 women and 5 men and had an average age of 68 years. We also had a group of younger subjects who also had no sleep complaints and were cognitively normal. They numbered 18 total with 10 women and 8 men, and they had an average age of 20 years. And in this work, subjects were excluded if they had more than mild sleep apnea present, defined by an AHI 4% greater than 15 per hour, or if subjects failed to find the target 2 or more times during their pre-sleep trials. So the experimental timeline looks something like this. We had subjects come in the evening, explore the maze for the first time, and then complete 3 timed trials on the maze. And then subjects were connected to polysomnography and had a standard diagnostic polysomnogram overnight. About 1 hour after awakening in the morning, they would complete a 20-minute psychomotor vigilance test for attention. And then at the completion of the psychomotor vigilance test, they'd complete their 3 final test trials on the maze. And all subjects completed a 3 Tesla structural brain MRI prior to the experimental night, and prefrontal cortical volumes were calculated using FreeSurfer. So shown here are measures of sleep architecture between younger and older subjects. And we saw, of course, the expected decrease in non-REM slow wave sleep in older subjects as compared to younger subjects. And this was compensated for in part by smaller but nonetheless statistically significant increases in non-REM stage 2 and REM sleep in older subjects as compared to younger subjects. Now, in addition to slow wave sleep amount, we're also interested in the power in these slow waves, which is called the slow wave activity. And we looked at this in a topographic sort of fashion and noticed that the slow wave activity was particularly decreased across the frontal leads, F3 and F4, in older subjects as compared to younger subjects. And finally, we're interested not only in amount and power of the slow waves, but also some measure of sleep continuity in these different stages. And this is represented in these tracings, where the probability on the y-axis is shown of sleep of any particular stage lasting the duration shown on the x-axis. And what we see is that for REM sleep and non-REM stage 1 and non-REM stage 2 sleep, that these curves are actually entirely overlapping for younger and older subjects. But for non-REM stage 3 or slow wave sleep, we see that there's a significant leftward shift of this curve for older subjects as compared to younger subjects, suggesting that slow wave sleep is the one stage of sleep that is particularly more fragmented in older individuals. And when we actually looked at the mean bout length of slow wave sleep, we saw that it was significantly different between older and younger subjects, with younger subjects having a mean bout length of slow wave sleep of nearly 6 minutes, where it was much shorter at just 2 minutes for older subjects. So shown here is the pre-sleep completion time performance on the maze between older subjects, shown in gray, and younger subjects, shown in white. And perhaps not surprisingly, we see that older subjects are taking longer on average to complete their pre-sleep trials as compared to younger subjects, and this was statistically significant. But when we actually looked at how performance changed compared to their baseline, we actually saw that older subjects and younger subjects seemed to get relatively better equivalently across their first 3 trials, such that older subjects got about 27% better between trials 1 and 3 before sleep, and younger subjects got about 24% better between trials 1 and 3 before sleep. And this is important because it suggests that both younger and older individuals are able to appropriately encode the spatial material and act on what they've learned to improve to relatively similar degrees. So now what happens after sleep? So even though older subjects are starting from a much higher baseline, and you'd expect there'd be a lot more room for improvement, we see that older subjects actually get a very small 4.8% performance improvement that was not statistically significantly different than their evening performance. In contrast, younger subjects get actually 31% better in the morning, and this was statistically significantly improved compared to their evening performance. Additionally, when we look at the percent change in completion time as a function of this power in the frontal slow waves, we see that there's a significant positive correlation suggesting that the higher the relative frontal slow wave activity, the more likely that you're going to get better across the night on the spatial navigation task in terms of your completion time. Importantly, we saw no differences in the psychomotor vigilance testing in the morning between younger and older subjects, so there were no differences in mean reaction time and no difference in the number of lapses on the PVT. And this is important because it suggests that any change in performance in the morning between younger and older subjects is unlikely to be due to any sleepiness or inattention that may have resulted from differences in sleep architecture between the two groups. Now, this measure of frontal slow wave activity also very significantly correlated with medial prefrontal cortical volumes across all subjects. And when we looked just in the older subjects, we saw that measures of slow wave sleep, either by this frontal slow wave activity shown in red, or simply looking at just total slow wave sleep duration shown in green, had a significant inverse correlation with levels of beta amyloid in the spinal fluid of the older subjects. And so, what does this mean? Well, it's known that levels of beta amyloid in the spinal fluid are low by the time someone has full-blown Alzheimer's dementia as compared to age-matched controls in people who are cognitively normal. But we and others think that there may be this model of how beta amyloid changes over time in the spinal fluid shown in red, where it has this inverse U-shaped curve where initially levels of beta amyloid in the spinal fluid go up before reaching some tipping point and then going down. So at cross-section, what we think we're seeing is people on this side of the curve, where having low slow wave activity is associated with having higher beta amyloid 42 levels in the spinal fluid and kind of pushing people toward this tipping point, whereas people with higher slow wave activity are perhaps protected by having lower levels of beta amyloid 42. Now, some evidence for this model comes from work looking at associations between beta amyloid and tau in the spinal fluid. So fortunately for our field, tau is a lot easier and more straightforward. Tau pretty much only goes up over time, and it goes up to a higher degree in people that are prone to developing Alzheimer's disease. And so this was work where levels of tau and beta amyloid 42 in the spinal fluid were amalgamated from a few different cohorts. And what they did was they broke the ages of these individuals down into quartiles. And so when they looked at the earliest quartiles from ages 45 to about 63 and from 63 to 70, they saw that there's actually a positive overall association between beta amyloid 42 and tau, such that as tau goes up, so does beta amyloid 42. But when they looked at the older quartiles of age, from ages 70 to 76 and from 76 to 90, they saw that overall there was this negative relationship between beta amyloid 42 and tau, suggesting that as tau continues to go up, that actually beta amyloid starts to go down. And so this was the direct conclusion from this work that says we found that the relationship between beta amyloid 42 and tau changes with age. Between ages 45 and 70 years, there's a positive linear association, whereas between 71 and 90 years, there is a negative linear association between A beta 42 and tau. So some of the conclusions from this work include the fact that aging is associated both with decreased slow wave sleep and increased slow wave sleep fragmentation. Aging is associated with decreased consolidation of spatial navigational memory without significant changes in morning psychomotor vigilance. Overnight performance change is positively correlated with frontal slow wave activity, and frontal slow wave activity is positively correlated with medial prefrontal cortical volume. So taken together, we think these data contribute to an emerging model in which medial prefrontal cortical atrophy with aging leads to slow wave sleep disruptions that subsequently lead to impaired memory consolidation acutely, and can also lead to elevated levels of beta amyloid acutely, which over time may predispose someone to developing plaques and impairing spatial memory in that way. So far I've been telling you a lot about this relationship between beta amyloid and slow waves, and we're wondering whether there might be some marker of sleep that predicts levels of tau in the spinal fluid, because we actually looked at whether tau was associated with slow wave activity and found that there were not any significant relationships. And so this is work that's spearheaded by Corey Kam, who's a postdoc in my lab. And there was a couple of reasons why we thought that spindles might be a marker of sleep architecture that associates with tau, and it's for these couple of reasons. So first, we know that spindle density is a rough correlate of intelligence and involved in forms of sleep-dependent memory processing. Brain tau load correlates with cognitive capacity and actually does so better than beta amyloid does, so both spindles and tau are linked by their connections to cognition. And we know that spindle density is something that also decreases with age. And so, sure enough, when we looked at levels of CSF tau levels we saw that there was this inverse correlation with spindle density in non-REM stage 2 sleep. And we looked at a couple other measures of spindles in addition to density. And so we saw that some other features of sleep spindles, such as just count, total count shown in panel B, spindle duration shown in panel C, or the frequency of fast spindles, which are spindles generally in the 13 to 16 hertz range, all showed this negative association with levels of tau in the spinal fluid. And this correlation remained significant when controlling for age and sex. And these correlations were also present, but somewhat weaker, between tau and spindles in other stages of sleep. So when we looked at spindles in stage 3 non-REM sleep, or looked at spindles in all of non-REM sleep as a whole, these correlations also existed, albeit somewhat weaker than in non-REM stage 2. Now, having defined this relationship between spindle density and tau, we really wanted to vet this relationship a little bit more. And we wanted to vet it in two ways. We wanted to, first of all, really ascertain that it's tau that's really specific to the association with spindles, and not that it might be some other Alzheimer's disease biomarker. And conversely, we're also really interested in making sure that there's something specific about spindles that predicts tau, and it's not just some measure of poor sleep in general. So we did some regression modeling to try to suss this out a little bit. And in the first regression models, we used spindle density as the outcome variable, and then we plugged a bunch of predictor variables into these models. And in the first model, we just included age, sex, and ApoE4 genotype as the predictors for spindle density. And we saw that age, sex, and ApoE4 combined to predict 12.8% of the variance in spindle density. And then on top of that, we added, one at a time, the concentrations of either A beta 42, phosphorylated tau, or total tau, and saw that adding A beta 42 contributed an additional 8.8% of the variance to spindle density. The phosphorylated tau added an additional 18.1% of the variance of spindle density, and the total tau predicted an additional 25.9% of the variance in spindle density. And then we took pairs of these AD biomarkers together, and when we added total tau and A beta 42 together, we actually saw that tau remained a significant predictor of spindle density, but A beta 42 no longer did. And similarly, when we added A beta 42 and phosphorylated tau together, we saw a similar pattern, which was that A beta 42 was no longer a significant predictor of spindle density, but phosphorylated tau was. So taken together, this data indicated to us that a couple things. One was that tau is really the strongest predictor of spindle density, much more so than beta amyloid 42. And then, in fact, when you account for both of these together, that the degree to which beta amyloid 42 alone predicts spindle density is probably a result of its intrinsic associations with tau. And then when you add these things together, A beta 42 falls out. So now, conversely, we're interested, having established that tau is the predominant AD biomarker that predicts spindles, we wanted to determine whether, the extent to which spindles were really the specific predictor of CSF tau levels. And so we, again, did some regression modeling where initially we included just age, sex, and ApoE4 genotype as predictors for now CSF tau, and saw that those three together predicted 7.7% of the variance in CSF tau. And then similarly, we went and added one sleep variable at a time and saw that of all the sleep variables, that spindle density in stage N2 contributed an additional 28.4% of the variance in CSF tau levels. And then we went and added these other sleep variables and found that none of them were significant predictors at all. And they included a bunch of different things, including things like slow wave activity, the amount of time of wake after sleep onset, sleep efficiency, two different markers of apnea severity, total sleep time measured in the lab with polysomnography, and then also total sleep time at home over 7 days that was measured with actigraphy. So none of these other sleep variables were significant predictors of CSF tau levels. So now, having established this relationship between tau and sleep spindle density in non-REM stage 2, we wondered whether this might have some functional implications for older people. And unfortunately, we didn't have a very high number of these people that completed an actual sleep-dependent memory task, but we did have all of them do some pretty standard daytime neuropsychological testing, including these tests that are shown here. So one of the tests we had people do was something called the digit symbol substitution test. And this is just simply a test where numbers, digits 1 through 9, are encoded by these different symbols. And then you're given a little time to practice this and put the symbols in, these boxes here. And then once you reach the thick black line, you're actually timed. So you get 90 seconds to fill in as many of these as you can. And the more you can do in 90 seconds, the better your performance. So that's the digit symbol substitution test. And then we also had people do tests called Trails A and B, which are essentially versions of connect the dots. So Trails A literally is connect the dots. It's just connect 1 to 2, 2 to 3, 3 to 4, and so on. There's 24 total items, and you're just timed. You're asked to do this as quickly as you can, so lower time is better on this test. And Trails B is similar, except that now numbers are interdigitated with letters, so you have to connect 1 to A to 2, 2 to B, B to 3, and so on. And again, there's 24 total items in this, and you're tested for speed. So similarly, lower time is better performance. And so relationships between spindle density and some of these neurocognitive performance measures are shown here. So the cognitive performance measures are the Trails A, Trails B, and digit symbol substitution test. On the left-hand side of each of these tests are the just sort of raw bivariate unadjusted correlations. And then on the right-hand side, we list the correlations that are where the cognitive test is actually adjusted for age, sex, race, and years of education. And so we saw some interesting things, which included the fact that both total spindle density across the full frequency range of spindles in the 11 to 16 hertz, as well as just fast spindles in the 13 to 16 hertz range, significantly correlated with Trails A performance, both unadjusted and adjusted. Additionally, fast spindle density significantly correlated with the digit symbol substitution test at the unadjusted level, but not after adjusting for the covariates. And then somewhat interestingly, we actually saw that there was this significant but inverse relationship between slow spindle density and Trails B, such that higher levels of slow spindles seem to be bad. It actually, you took longer to perform Trails B the more slow spindles you had. So to summarize this portion of the work, we demonstrated that low spindle density is associated with high CSF tau concentrations, and that CSF total tau explains greater variance in spindle density than levels of beta amyloid 42 in the spinal fluid do. We demonstrated that spindle density in non-REM stage 2 sleep explains the greatest variance in CSF total tau levels among multiple sleep variables. And the directionality of this relationship remains to be explored. So we don't know whether it's tau that's driving spindles or spindles that's driving tau, or possibly neither, or it could be just an epiphenomenon. But we do think there may be some functional relevance, and that spindle density does seem to predict at least some neurocognitive performance outcomes. So now I'm going to switch gears a little bit and talk about obstructive sleep apnea. So as you guys likely know, obstructive sleep apnea occurs when soft tissues in the upper airway collapse repetitively, leading to two main consequences, which are shown here in this polysomnogram on the screen. So this is what a pretty standard PSG looks like. The EEG activity is shown here on a 30-second time window. Breathing is shown in this blue trace, also on the 30-second time window, and then more of the breathing variables are shown in this expanded time window that is 2 minutes overall. And so in this individual who is having repetitive apnea, as we see the breathing shown in this blue trace goes from some pretty normal sinusoid to basically an absence of flow. And at the same time, we see that there are efforts still going on in these effort belts demonstrating that these events are in fact obstructive. And we see that, of course, along with these cessations in breathing, that levels of oxygen saturation shown in this red tracing here are fluctuating. They're going from normal levels in the 90s down, in this case, to pretty significantly low levels in the 70s and cycling again. So that's what we call intermittent hypoxia. And the other thing that happens with these apneic events is shown in the EEG, where, as you can see, when the breathing stops and then this person takes a recovery breath, we see that there's a sudden burst of high-frequency activity in the EEG, along with a burst of activity in the muscle tone in the chin, suggestive of an arousal. So this is the other hallmark of sleep apnea, which is sleep fragmentation. And just to give you guys a little primer on the nomenclature of respiratory events, apnea is pretty easy to define. It's just no breathing for 10 seconds or more, and you don't have to have any other qualifying criteria to define that. Hypopnea, on the other hand, is simply reduced breathing, and the American Academy of Sleep Medicine requires that there's a reduction of the amplitude of breathing by at least 30% or more from some baseline level. And this reduction in breathing has to last at least 10 seconds, and it has to be associated with some outcomes. So if that hypopnea is associated with a drop in blood oxygen saturation of 4% or more, we call that a hypopnea of 4%. However, if it terminates in a 3% or more drop in blood oxygen saturation or terminates in arousal, it's called a hypopnea 3A. And the apnea-hypopnea index, or AHI, is simply just the number of apneas and the number of hypopneas added together across sleep and divided by total sleep time. But because there's two different definitions of hypopnea, we end up with two different AHIs that we like to define as an AHI 4%, which is the metric that really captures more of the intermittent hypoxia, and then something that we call an AHI all, or sometimes an AHI 3A, that's reflective of either the desaturations or the arousals. And it turns out that if you have an AHI 4% greater than 5 per hour, or an AHI all greater than 15 per hour, plus daytime symptoms, and typically that's daytime sleepiness, then you're said to have the obstructive sleep apnea syndrome, or OSAS, and the estimated prevalence of the obstructive sleep apnea syndrome is about 4% across the US population. Now, if you have just an AHI 4% greater than 5 per hour, or an AHI all greater than 15 per hour, whether you have daytime symptoms or not, you're said to have OSA somewhat more generically. And in this case, the prevalence of OSA is much higher. So it's about 20 to 30% across the population. But it's even higher in people that are older. So we think that the prevalence of this kind of more generic obstructive sleep apnea prevalence is about 30 to 50% in older individuals. And some of this work comes from this Hypnolaus study, which was a large epidemiological study coming out of Switzerland that had more than 2,000 subjects with an age range of 40 to 85 years. And so apnea by severity categories is shown in these bar charts here, separated by gender between men and women. And the light blue bars are indicative of older individuals, those that are greater than or equal to 60 years old. So we see that in men, there's actually 66% of men have an AHI 4% of at least 15 per hour, half of whom, or 33%, have an AHI all between 15 and 30, which we'd qualify as mild obstructive sleep apnea, and then 33% having an AHI all greater than or equal to 30 per hour, which we categorize as more moderate to severe. And in women, the numbers are about 40%, so we get about 23% of older women that have an AHI in the 15 to 30 range, and then about 15% that have an AHI greater than 30. So we've been following a cohort of cognitively normal older individuals. They're cognitively normal by virtue of having clinical dementia rating scores of 0. They're screened for depression and found to be non-depressed. In our cohort, they have an average age of 68 years with a range of 55 to 90 years. And these older people have done a bunch of things for us. So they complete a home polysomnogram at baseline. And the home polysomnogram is really good for determining apnea severity. It's not so great for determining sleep architecture changes. They also do a lumbar puncture for us, and then they do some brain imaging, which includes both structural MRIs as well as amyloid PET imaging. And so here are some of the characteristics of this cohort divided by apnea severity. So this is kind of ongoing work, but at the time we did this analysis, we had 208 of these older subjects, and we saw that 46.6 of them had normal sleep breathing, but of course that means that greater than 50% have at least mild OSA in our hands, which is similar to what's seen in Hypnolaus. So in our hands, we see that about 36.5% of these people have mild obstructive sleep apnea, and 16.8% have more moderate to severe obstructive sleep apnea. Now, despite this high prevalence of obstructive sleep apnea, we actually see that there's not a lot of daytime sleepiness going on. So shown in this row is the Epworth Sleepiness Score, or ESS. This is a 24-point questionnaire that asks people about the likelihood of falling asleep in a variety of different situations. And clinically, we think that scores of 10 and higher are indicative of clinically meaningful levels of sleepiness. But these subjects have very low Epworth sleepiness scores. So the entire group has an average Epworth sleepiness score of 5, and it ranges only from 4 to 6 across the different OSA severity categories. Additionally, these older people are sleeping a pretty normal amount of time. So on average, the group is sleeping 7 hours, and it ranges from 7 to 7.5 hours across the different OSA severity categories. So we were interested in asking questions about what obstructive sleep apnea in these older people might be doing deleteriously for memory. And so we wanted to look at how these people did on the same spatial navigation task that I described earlier. And so this is work that's really spearheaded by Mastery Williams, who's a second-year medical student here at Mount Sinai, as well as Anna Mullins, who's a postdoctoral fellow in my lab. So in this work, we had a group of older subjects who had no obstructive sleep apnea. These were subjects who were cognitively normal by neuropsychiatric testing and had no sleep complaints. So I should point out that these are people that were essentially recruited from the community, not recruited from the sleep clinic, so no sleep complaints. They numbered 30 total with 19 women and 11 men, had an average age of 67 years, and they had a median AHI-all of 5 per hour, which puts them well within the normal range. And then we compared them to a group of subjects that were older and had obstructive sleep apnea, who also had no sleep complaints and were cognitively normal. They numbered 12 total with 7 women and 5 men, had an average age of 66 years, and they had a median AHI-all of 21 per hour. So this puts them kind of well in the middle of the mild range of obstructive sleep apnea. And in this work, subjects were excluded if they failed to find the target 2 or more times during their pre-sleep trials. So shown here are some of the sleep architecture measures between individuals with and without sleep apnea from this older group. And of course, by design, we saw that those subjects with obstructive sleep apnea had significantly higher degrees measured by either an AHI 4% or an AHI-all. We also saw that this total arousal index was higher in subjects with obstructive sleep apnea as compared to those without. In terms of the sleep architecture, we saw that there was a significant increase in the amount of light non-REM stage 1 sleep in subjects with obstructive sleep apnea, and a significant decrease in the amount of non-REM stage 2 sleep in subjects with obstructive sleep apnea, but notably no significant differences in non-REM stage 3 or slow wave sleep or in REM sleep, although on average the numbers were a bit lower, as you might expect, compared to those people that had no obstructive sleep apnea. So what happens with this overnight change in completion time? Well, for the subjects without obstructive sleep apnea, we see that there's about this 5% performance improvement overnight. This is very similar to some of the data I showed you earlier when the older subjects were compared to younger subjects. When we looked at the subjects with obstructive sleep apnea, they actually were getting worse overnight on average. So their performance went about negative 10%, so they're getting about 10% worse across the night as compared to their pre-sleep trials. As you can see, there's a lot of scatter in this data, so it turns out that although people with OSA are performing worse in terms of this percent change in completion time, this is not significantly different than the performance of people without OSA. We wanted to look at this a little more carefully by looking at their trial-by-trial performance to get a more nuanced picture of perhaps what's going on with the people that have sleep apnea in this older group. And so shown here is the trial-by-trial performance for individuals without obstructive sleep apnea, shown in the white circles. And this performance conforms to my preconceived expectations of how people probably should be performing on this task. So shown here is completion time, and what you see is that across the first 3 pre-sleep trials, people are getting faster, meaning they're doing better, and then they sleep, and then they come back in the morning, and overall they continue to get better and better by and large, and their 6th trial is their fastest and best trial overall. So that seemed to make sense. When you look at people with obstructive sleep apnea, if you look at their pre-sleep trials, there's really no significant difference. They also get a little bit better across their first 3 trials overnight, and this is not statistically significantly different than the way people without obstructive sleep apnea perform. But what happens in the morning is that they perform in a way that's very different than people with normal sleep breathing. So people with obstructive sleep apnea, shown in the gray dots, actually get worse and worse and worse across their morning trials, such that their sixth and final trial in the morning is actually their worst trial among all trials. And this was a statistically significantly different pattern of performance than people without obstructive sleep apnea. Similarly, we looked at psychomotor vigilance measures, including mean reaction time and number of lapses between individuals without and with obstructive sleep apnea, and saw that in this case there were no differences. Again, this is important because it suggests that this pattern of performance in the morning on these maze trials is unlikely to be due to significant sleepiness or inattention that may have resulted from the mild level of apnea in this group. So now, in addition to looking at acute effects on memory, we're also interested in understanding potential longitudinal effects of having obstructive sleep apnea on risk for Alzheimer's disease. And as I mentioned, we had this cohort that numbered 208 subjects total, and we actually had 109 subjects come back for a second LP that was performed about 2.5 years after the first. And we also had a smaller subset of 34 subjects that ended up completing a second amyloid PET scan, and again, this is about 2.5 years after the first. And so what we observed was that apnea severity, measured either by an AHI-all or an AHI-4%, predicted significant decreases in the levels of beta amyloid 42 in the spinal fluid over time. So again, to take you back to this model of how we think beta amyloid 42 is changing in the spinal fluid, we think we're capturing people who are now on this side of the curve and are starting to decrease their levels of beta amyloid 42 over time. And of course, if this is true, if we're right about this, then we should also see increases in cortical amyloid deposits in the brain. And so that's actually exactly what we saw when we looked at levels of amyloid in the brain itself by PET imaging. So AHI-all or AHI-4% was associated with a significant increase in the levels of amyloid by PET imaging over time in this group. Now, one of the other ways we're interested in understanding the relationship between sleep apnea and cognition over time was to do some data mining from this Alzheimer's disease neuroimaging initiative, or ADNI cohort. So ADNI is an active, ongoing cohort. At the time we did the analysis, there were 2,470 subjects, and they're followed for 2 to 3 years, and all this data is publicly available. And it turns out that there was a subset of 767 subjects that were available for sleep analysis. And these were subjects who completed sleep questionnaires with really sort of simple and rudimentary questions like, do you have sleep apnea, yes or no? And if you have sleep apnea, do you use CPAP to treat it, yes or no? And so even though the level of sleep data from this group was self-reported and relatively simplistic, one of the nice things about this group was that they were followed very carefully for their cognition. And in those people that ended up converting from normal cognition to mild cognitive impairment, which is thought to be an early harbinger for Alzheimer's disease, the precise age at which that conversion happened was known in this ADNI cohort. And so when we looked at onset of mild cognitive impairment between individuals with and without self-reported sleep disorder breathing, we saw that there was a significant difference between these groups. So individuals with self-reported sleep disorder breathing, shown in the green tracing, had a much earlier age of conversion to mild cognitive impairment than did people without any self-reported sleep disorder breathing, shown in the green trace. And the difference was pretty substantial. It was about 11 years. So individuals without sleep disordered breathing had an average age of onset of about 83.6 years, whereas those with self-reported sleep disordered breathing had an average age of onset to mild cognitive impairment of 72.6 years. And even though the number of individuals reporting use of CPAP was very low, when we looked at the survival curve for conversion to MCI in those people using CPAP, shown in the red trace, we saw that their curve actually looked fairly similar to what's seen in individuals with no sleep disordered breathing at all. And so the average age of onset to mild cognitive impairment in individuals who are CPAP users was actually 82.1 years, so fairly similar to those without any sleep disordered breathing at all. Now, additionally, in this ADNI cohort, we could look at not only age at which people converted to MCI, but we could actually look at how some of these AD biomarkers are changing over time. And this is work that was really spearheaded by Michael Bubu, who's a postdoctoral fellow in Ricardo Osorio's lab, who's a colleague of ours. So when we looked at some of these changes in AD biomarkers, what Michael found was that levels of beta amyloid by PET imaging were increasing to a greater degree in those with self-reported obstructive sleep apnea, shown in the red tracing, as compared to those without. Levels of beta amyloid in the spinal fluid were decreasing at faster rates, again, in the people that have self-reported obstructive sleep apnea. And then we saw similar patterns for tau. So tau, both total tau levels and phosphorylated tau levels were increasing at faster rates across about a 3-year period in those people with self-reported obstructive sleep apnea as compared to those without. So to summarize this portion of the work, we've demonstrated that obstructive sleep apnea is very common in elderly subjects, although often without daytime sleepiness. Obstructive sleep apnea alters spatial navigational memory processing in the elderly acutely, and greater OSA severity is associated with longitudinal decreases in CSF beta amyloid 42 levels and longitudinal increases in cortical amyloid deposits, both of which are thought to increase risk for the development of mild cognitive impairment and Alzheimer's disease. The presence of obstructive sleep apnea is associated with an earlier age of onset of mild cognitive impairment, and perhaps most crucially, obstructive sleep apnea is a potentially modifiable risk factor for cognitive decline. So with that, I'd just like to thank many of my collaborators that made this work possible, including David Rappaport and Indu Ayapa here at Mount Sinai, Ricardo Osorio at the NYU Center for Brain Health, and a really talented cohort of students and postdocs, including Corey Kam, Ankit Parekh, Anna Mullins, Michael Bubu, and Masari Williams, most of whom are here in the audience today. And finally, I'd like to thank my sponsors and you guys for your attention. I'll take any questions.
We have time for some questions. One of the major divisions of memory impairment in old or healthy people is obviously loss of immediate recall or loss of something from the deep past. And educated people, as you know, have given the name, oh my God, I've had a senior moment, when they're giving a lecture and they forget something that happened a moment ago. So my question for you is, do you study the difference between the two types of memory impairment that seem obvious to me? The older person's senior moment, when they forget something, but they have good recall of things that happened 50, 80 years ago. Have you studied the difference of these two entities with all your measurements?
Yeah, so the short answer is no, we haven't. The longer answer is, I think you bring up a good point, right? I mean, we know that, you can have some cognitive changes with aging. Some of that can be normal. As you said, I think it's normal to have, what's called the senior moment. What you really, I think want to pay more attention to is if those are becoming progressive, right? If they're becoming more frequent, if they're becoming or switching categories, right? It's not just for sort of forgetting a person's name, but it's other things, right? And I think you hit another important point, which is that long-term memories are really tend to be very preserved. So by the time those are starting to be affected, it's usually indicative that there's a bigger problem going on. It's the prospective memory tends to be affected earlier, right? Stuff that you sort of recently memorized or went to go to the store to get X, Y, and Z items, and by the time you got there, you can't remember. I mean, that's the kind of prospective memory. So, like I said, we haven't delved into this too much. I mean, I was talking with somebody before the talk started, and was talking about the fact that, in my opinion, I think more can be done with some of the neuropsychiatric testing that's done in people. Neuropsych testing is relatively straightforward, actually. And because of that, by the time people develop impairments in frank neuropsychiatric testing, they're often pretty significantly impaired. So it's my opinion that you should potentially push people with harder tasks on neuropsychiatric testing. You should take into account things like level of education, right? Because we know that cognitive reserve is an important protective factor for cognitive decline. And again, because I'm a sleep guy, I also think that it's potentially worth looking at cognitive tasks that are sleep dependent, meaning that it'd be great to have people encode something before sleep and then give them a period of sleep, even if it's a daytime nap, and then ask them to recall it later, because I think that's a paradigm that pushes the system a little bit more, and I think you can bring out cognitive deficits that way.
Please.
Thank you for an excellent presentation. Were all of these data collected independent of whether or not the patients were on medication to induce sleep? Or is there a correction for that in this presentation?
Yes, so all these patients were excluded if they were on any sleep medicines, any neuropsychiatric medicines. It's a little sort of project specific. I mean, some of the tests where we're looking at sort of pure cognitive things. In some cases, if you're on a single SSRI, you could still be included, but if you're on multiple SSRIs or any other strong neuropsychiatric medicine, stimulants, sedatives, sleep medicines are excluded.
And have you tested any of the rejected group and compared them with your current study?
No.
We have, please.
If you follow them longitudinally, can you predict progressive changes in the basis of the studies that you do?
In terms of
Cognition and so.
yeah, so we're doing that. So we're, like I said, this work was some longitudinal work that we reported the results after 2.5 years. We're following these people still and have some funding to continue following these people for another 5 years or so. So we think the changes in things like beta amyloid and tau biomarkers, as I showed in that early slide, are likely to be early harbingers for actual cognitive change. In terms of the number of people in our cohort who've actively converted from normal cognition to mild cognitive impairment, it's been very, very small. But of course, we think that as we follow these people longitudinally, that we're going to get higher numbers of people converting. So hopefully we'll be able to see that and demonstrate that things like apnea, severity have an impact on actual rates of conversion to different cognitive classes.
Great, Ben?
So, Andy, your epidemiological study suggested that the CPAP actually helped prevent the cognitive decline. But if you were to institute the CPAP later, how much of that could be recovered? Is any of this reversible?
Yeah, that's $1 million question, and there's surprisingly been not a lot done on this actually. So you can look at it from two different angles, right? One angle is, does CPAP do anything to improve cognition, right? That's not been looked at in older people specifically. It's been looked at as a whole in a wide range of people. This was a large clinical trial that was called Apples, and they saw some pretty modest effects. They saw, these people were put on CPAP and followed for, something like 9 months or something, and they saw some early improvements at like a 3 or 6 month sort of time point, especially in domains like executive function, that then seemed to kind of normalize at the later time point. That study is criticized a little bit for a couple things. I mean, one was that people who had sleep apnea who were randomized to CPAP or not in that trial had very mild sleep apnea overall. So people said, well, maybe it's really the people that have more moderate to severe sleep apnea, they're going to be more affected. And then the other thing is that these were, like I said, relatively youngish and cognitively normal people. So if you have a pretty cognitively normal baseline, where's there going to be room to improve, right? So some people have said you really need to take people who are actually starting to show some cognitive deficits to see that there can be some improvement, right? So that's on the cognitive side. And then the other thing you'd like to sort of see is, does CPAP actually, change the course of accumulation of some of these AD biomarkers? And again, that work hasn't really been done. I mean, there was a very small study, if I'm remembering correctly, of people that were put on CPAP, and they looked at some of these biomarkers, and there did seem to be some improvement, but I think a lot more work needs to be done. And I'm not sure really what the result's going to be, because people don't develop sleep apnea overnight, right? They tend to have sleep apnea for long periods of time, and if you're someone who's let's say 70 and being diagnosed with sleep apnea for the first time, I mean, there's a chance you might have had sleep apnea from the time you were 30. And so are there these decades-long changes that happen to the brain as a consequence of obstructive sleep apnea that are irreversible? I mean, that may be possible. So like I said, I think the data right now is pointing toward obstructive sleep apnea being a significant risk factor, but the extent to which that's reversible is, like I said, it's the million-dollar question. And our group and others are, like I said, are making some headway in this. So it sort of remains to be seen. But the NIH has reached out to our group actually about doing a clinical trial with CPAP and/or potentially other things for the treatment of obstructive sleep apnea. As you may know, one of the bugaboos, of course, of any clinical trial for CPAP is that everybody hates it, and nobody really uses it very well. So David Rappaport, who's in our group, has championed this idea that you should do a clinical trial where the intervention is anything that reduces the AHI, whatever that may be. It could be CPAP, it could be an oral appliance, it could be positional therapy, it could be a combination of all these three, but do anything you can to reduce the AHI, and then do a clinical trial that way, and hopefully you get sort of better overall adherence and can maybe have more quality in the study.
Let's thank Dr. Martin for